Hello, everyone. We're ready for a CCO student webinar. We're at number 65. Welcome. Tonight we have a really good subject that is often asked about by the students. When you first start learning about coding with a neoplasm table, coding for malignancies and cancer, it can be kind of confusing. Now, we have done a lot of content already on coding for cancer, the different types of cancer, the location, the severity, and complications. We haven't focused too much on secondary cancer specifically. So that's what we're going to talk about tonight is secondary cancer, how to code it, and why it's different than primary cancers, and explain metastasis or metastases a little more in depth. I've got some outside resources that I'm going to show you, and I want you to have a notebook ready so that you can make little notes. And then also, as we're going through these, I'm going to pull in how I do research so that you can get some practice in doing that as well. The first thing we're going to talk about is actually what's the difference between primary and secondary cancer. The best way to do this is to take a very, very common cancer that everybody is aware of, and that would be breast cancer. So if we look at the neoplasm table, and again, we have education on the neoplasm table. You'll find that in your textbook as well as in your ICD manual. So you might want to go ahead and have your ICD manual there in front of you as we go through, and you might want to make some notes in the notebook as well. And then later, if it's helpful, you can actually include those notes into your ICD manual. I've done that a lot of times. So the difference between primary and secondary cancer is shown on the neoplasm table. The cancers are listed in the tabular section of your manual alphanumerically. That's you'll notice that when you go and you look at the beginning of the code set, it starts at A, right? And then it moves to where you get to the C's. The C is easy to remember, cancer. You'll have C and D codes that are cancer codes. A little tip, the neoplasm table is set up and cancer codes are set up to start with primary first. And if you look at the list that I created here that just comes from the top of the neoplasm table, primary, secondary, cancer in situ, benign, uncertain behavior, and unspecified behavior. Also, if you're not familiar with the difference between uncertain and unspecified behavior, we have further education on that. I would say that you want to be able to distinguish between the two and the verbiage that's involved with that before you go test, because they will throw those codes in there to see if you understand the meaning of them. Going back to primary, the little tip I wanted to give you is they start with primary, so the lower the number, the more likely it is to be a primary cancer. The higher the number, the more likely it is to be a secondary cancer. Now, where the cutoff is, I can't remember, but let's look at an example here. When we see breast cancer, and it's just breast cancer, there's no other information regarding it's of the connective tissue or kind of a catch-all, that's a C50.9. I color-coded it so that you could see that it means primary. And then the secondary code for breast cancer of the same area, same description, is C79.81. Look at the difference between the gap of the numbers, excuse me. So 50 is a much lower number than 79, right? It's because it's alphanumeric. And the listing of the codes go primary, secondary, CIS, and benign, right? So again, pay attention to that. If you get into a D code, it will be a most likely, it could be a secondary cancer, but most likely it's a benign cancer if you get all the way into the D's or one of those uncertain or unspecified. That's just a little tip that will help you as you get to becoming more familiar with the code set. And this is going to help you test. It's going to allow you to kind of look at those codes quickly and think, oh, wait a minute, this is a C48. And then next to it is a C75. Well, if I have to just guess by looking at it, and it says it's a primary cancer, then it's probably the lower code, right? Now, that doesn't mean you can do that without looking it up, but if you're testing and you really are scrambling to make up time and you skipped this answer because you need to come back to it later to save time, that will help you if you have to make an educated guess. So make a note of that. The higher the number, the less likely it is to be a primary cancer. All right, primary I put in green, and purple I put in secondary so that you could see. And then the next would be cancer in situ of the D05, and then benign would be D24, et cetera, et cetera. And that's how the neoplasm table works. It's all done literally on a table. Instead of a graph. You can follow it along. And another tip is, and they'll tell you to do this, don't code from the neoplasm table. Jump out to the tabular to confirm there's no other guidelines. There's no guidelines listed on the neoplasm table. It's really just an index for you to get you to the right code, to jump out to the tabular to verify that you've got the proper code. So that's the difference between the codes for primary and secondary cancer. Much more information we need to get through. I'm just going to scan right here to see that. All right. Okay. The reimbursement for DRGs, we'll discuss that at the end. Okay. Malignant neoplasm does not tell you whether it's primary or secondary. That verbiage does not say primary or secondary. However, if you see the term secondary, then you know that that is a cancer that has gone from one point to a secondary site. The other verbiage that you will see is metastasized. So if a person has breast cancer, and you could be male or female and have breast cancer. So if you have breast cancer and it metastasizes to another organ, that is secondary cancer. That second site, it has metastasized or moved to another site. Really what this means is the cells that are abnormal or cancerous have taken a pathway to another area. Sometimes it goes via bone, or excuse me, the lymph nodes. Sometimes it goes through the bloodstream. Sometimes just because it's in contact, the organs would be close together, right? And so it has transported from one area to the other. But those abnormal cells, the way they know that it's a secondary cancer and not a new cancer that just started up, is that they see that tissue, that abnormal tissue, breast tissue, in the secondary organ location. And I have some examples of common breast cancer metastasis where that breast cancer likes to go. And how do we know that breast cancer likes to go in specific areas of the body? We know this because of the codes. We translate the codes. We translate the documentation to a code set, and then that code set is used for statistical purposes. You hear me say that all the time. We code for statistical purposes. It just happens to be a convenient way to get paid. We don't want to be writing out in paragraph form that the patient has malignant neoplasm of the breast that moved to the bone. And it's easier to just drop 2 codes that tells the whole story, saves space and time, and allows us to track the data. And therefore, we can see how prevalent each type of cancer is, and even the specificity with cancer. They've divided up the breast in regions and quadrants, and you can see if there's overlapping sites. You can see if it's one particular area. If the upper left-hand quadrant cancer of the breast, does that go to the lymph nodes faster or metastasize more likely than a lower right quadrant of the breast? They would know that, and they can tell by the type of cells that look at the cancer and then say what type of cancer, whether it's ductal cancer or not, for example. And all of that is coded so that the information can be captured. So let's move on and look at an example of 2 codes. These are both secondary codes, not primary codes. The secondary code would be for the breast C79.81, and that's a generic. Back at that other, when I listed the codes that were on the neoplasm table, whenever you see the point dash, that means there's more characters to define, okay? So they won't list all the specificity in the neoplasm table. It's just an index to get you out to the main aspect of the code, and then you get the specificity. So I didn't mention that, and I should, especially if you're new to the codes. So whenever you see a dash, that's telling you don't stop there. There's more codes involved, more characters, excuse me. So C79.81 is secondary malignant neoplasm of the breast. So the person has breast cancer that has come from someplace else. And that means that it could have come from the brain, the lung. You would go look and see what the primary cancer was and know that that's the tissue that showed up in the breast. Then the other code is C79.51, secondary malignant neoplasm of the bone. This indicates that the patient has cancer of the bone, but it's from someplace else, okay? Both of these are secondary cancers. They can be listed first when the sequencing is being done. And I know that gets confusing too, because you think, well, but it's the secondary cancer. Doesn't it go second every time? And the answer is no, it does not. If the person has a primary cancer of the breast and it metastasizes to the bone, wherever the patient is being treated, what cancer is being treated that day is listed first. So let's say that the patient has a primary cancer of the breast, secondary cancer of the bone, and they're going to see an orthopedist. And it's due to a fracture in the leg, okay? Because again, there's a tumor in the bone, and it's caused a pathological fracture. Is the provider, that orthopedist, going to be treating both cancers? No, he's not even really treating one. He's treating the fracture. Why was the fracture occurring? Because of bone cancer. The bone cancer is secondary. It came from breast cancer. So the sequencing would be, in that scenario, the patient is being treated for the fracture. That's the first code. Secondary bone cancer would be the next code. And then the third code would be primary breast cancer, because that's the order in which the provider is treating the patient. The caveat to that is that if you go to the oncologist, and the oncologist is treating both the breast cancer, which is primary, and the bone cancer, which is secondary, then if both cancers are being treated that day, then you would list them as primary and then secondary. Let's say that they're going to do a biopsy of the bone. Then it's the bone cancer that's sequenced first, and the secondary bone cancer, and the primary cancer of the breast second. Now, this follows through with the code set, with other codes. Whatever's being treated that day ends up being listed first. And this makes a difference for, I know someone mentioned the DRGs. Those are listed in billing for what is the reason for the visit, and secondary cancers carry more weight than primary cancers because that means the patient is sicker. The cancer has moved, metastasized, spread. This also carries weight with risk adjustment. So if you're interested or you're involved in risk adjustment, you want to make sure that every time a person has a secondary cancer, that it's coded out as secondary and not primary. And that error does occur from time to time. It's a missed opportunity because, again, the patient is sicker and needs more care if the cancer has already metastasized. Some other areas that the patient can have breast cancer metastasize to the brain, the lung, we mentioned the bone, and also the liver. These are pretty common areas, and we know that because of the codes that have been captured throughout the years. There is a difference between solid cancers and liquid cancers. Solid cancers would be breast cancer, brain cancer, all of the ones shown here are solid cancers. They would have a mass, think of it that way. But if a patient has cancer of the bone marrow, that's not solid, that's liquid, as well as the lymphatic system or the bloodstream. Those are considered liquid cancers, and those are cancers that spread throughout the body. So if you have a cancer of the lymph nodes, that is like saying, I poured my soda in the river. Now, where is the soda in the water? You don't know. If it's a river, it's moving. It's out there, right? There's no way to pull it back. It's anywhere, right? Or you could say, I took 5 empty water bottles and I threw them into the creek. And where are they at now? So a couple of them may have got caught as the creek turned a little bit and it's up against the embankment. One may be a mile away. One might be, caught up on a tree limb. One might have got a hole in it and sunk, right? So again, those are liquid cancers, and therefore they can still be secondary. However, they also don't really go into remission. But that's another subject that we've done education on the type of solid and liquid cancers. But I wanted to let you know that as we explain how primary and secondary works. Secondary malignancies are often found with PET scans, and this is using technology that's classified under radiology. What they do is they put an IV in a person, and it has glucose, sugar water in it. And then they also add some radioactive material and shoot that through the body, and it pools wherever the cancer is. And so these are graphics kind of showing you the hot spots of where cancer can show up. I have put at the resource page of the slide deck the links where I got this information, and we're actually going to look at the website where I got this because it is a Auckland Radiological Center, and there was some good information about bone cancer. Bone cancer tends to be a secondary cancer often, and so you can see here kind of how that how that works, all the different places that it can detect a tumor. Not necessarily always bone. You notice that here we have lung cancer, but we have it in the ankle, in the spine, different bone cancers. Some like to go into the neck and cervical spine, and some like to go into the lumbar, and then other bone cancers go into the legs. But again, this is also showing you a brain tumor as well as cancer of the digestive tract. Right. So I just kind of wanted to give you that information. If you are interested in this, I will tell you that whenever you're doing oncology or coding any type of cancer, whether that's the primary care that you're working in, you're working for an oncology site or an oncology doctor, what's going to benefit you the most is learning the anatomy. All cancers are locationally sited. So knowing the proper verbiage, knowing all of the bones, their names, all of the different body systems and their names at a very high level is going to help you be better at your job. It's going to save you time from looking up information. So I would encourage you, as you progress through the course, that you take time to jump out and read as much as you possibly can, in addition to what you're doing for the coursework. If there's ever a time where you think, I don't really remember what that word means, or she mentioned a different part of the anatomy that I hadn't heard it referred to as that term, or maybe even giving you the example of a PET scan, right? I don't know what a PET scan is. I better go look that up and read a little bit more about it, right? Because again, you're not doing the diagnoses. You're not doing only diagnoses. You're needing to be able to pull the CPT codes in as well. Why would a person have a PET scan? Well, they're looking for something at a higher level than just doing a CT, an MRI, or a regular chest x-ray, right? Now getting back to secondary malignancies, how does breast cancer move? We like to think that it's through the lymph nodes, because we hear that and see in the documentation so often that if a person goes in and has a biopsy done, they usually go pull some lymph nodes in the axillary area whenever the patient has breast cancer or suspected breast cancer, because they want to know if those cells have reached the lymph nodes, because that's the bottle in the creek, right? If it's there, then the possibility is that it could be throughout the body and metastasize someplace else. And so that's one of the first tests they do. However, keep in mind that even if they find breast cancer cells in the lymphatic system, that doesn't mean that the patient has lymphatic cancer secondary to the breast cancer. It just means that they have the cells there, and that they will start testing and looking in other areas just in the event that the cancer has spread. And I know that when my mother had breast cancer, she had no lymph nodes involved. And she had a very, very large mass. And I said, well, is that unusual to have such a large mass and not have the lymph nodes involved? And the oncologist said, actually, no. She said, I have seen breast cancer that was extremely tiny, that the tumor itself was, like the size of a pencil eraser, and it had metastasized into the lymphatic system and moved throughout the body. So it doesn't mean just because that the cancer is found up by the lymphatic system or that the tumor is large, there's not a significance as to whether it's going to spread or not due to size and location. However, it for breast cancer. So that's why you want to pay close attention to the details when you're looking at the documentation for breast cancer. However, do keep in mind the lymphatic system is very, very important when any patient has cancer. And so, again, it doesn't necessarily mean that the patient has lymphatic cancer. The verbiage that you're going to see is regional and nodal. They'll take lymph nodes. They'll consider that regional occurrence if it's not distance recurrence. So, in other words, breast cancer that has metastasized to below the equator or the waist and is in the bone, right? Or uterine cancer. So keep that in mind, and that also makes a difference in the staging. We've done a lot of education in addition when talking about cancer about the staging that's involved. Where do secondary malignancies like to go? Now, I took this from Find a Code, and I have that resource listed for you, but they divided up the most common areas, and this is off of the breast cancer code. So I looked at the breast cancer code, and then the additional information that's provided is talking about where cancer likes to metastasize. So it can go to the kidneys or renal pelvis, it can go to the bladder or other urinary organs. And when you say that, it's like, well, what other urinary organs are there? Well, that's the ureter and the urethra. You can have those there, the little bits of cancer there. Then you have skin. And we forget that the skin's the largest organ of the body. Think of melanoma. And melanoma is one of the fastest spreading type of cancers. Skin cancer that's melanoma likes to go down instead of spread out, and its little fingers get into the bloodstream and the lymphatic system and like to just explode and take off. So it is one that's a little scarier than some of the other cancers, in my opinion. We have brain cancer as well as cerebral meninges, which is that layer, those layers around the brain that can protect the brain. Other parts of the nervous system, which could be the spinal cord or peripheral nervous system. You can have cancer of the spinal cord. Now, cancer of the spinal cord is different than cancer of the spine because that's the vertebra. Make note of that, especially when you're being tested, because the verbiage in the description looks different or looks similar. And so know that if a person has cancer of the spinal cord, that's nervous system, but of the spine, that's bone cancer. Bone, of course, bone marrow, which is considered a liquid cancer because bone marrow produces blood components and then it goes out throughout the body. Ovaries, which is actually a gland. Don't think of the ovaries as just a reproductive organ. Also remember, it is a gland. Adrenal glands, the breast, of course, and other genital organs which are used in reproductive. So the prostate is a gland for the men, but you can have testicular cancer, right? I went ahead and found this great study, and I'll show you the site that it came from, that in 2013, and we know this because of statistics, and this particular article was from 2014, and there may be other articles that are, with other statistics now that were that was quite some time ago. But I found it very interesting, and this also explains why coding to the highest specificity is so important, why our jobs make a difference. That in 2013, they looked at a study of breast cancer, early stage breast cancer, so it's first noticed, and then where is the frequency of metastasis? Where does it go? 41% went to the bone. 22% went to the lungs. The liver and the brain kind of tied there at 7.3. But all less common sites, they clumped them together, and it averaged out at 22.4%. So that's why I used bone cancer as an example of the breast cancer metastasizing to, because almost half of the patients that have breast cancer and it reoccurs someplace else, it hits the bone. And that's another thing that you'll be looking at when you are coding out in the field. Whenever you have a person that has had breast cancer, the providers are going to be very sensitive to pain, joint pain. Is it arthritis, or have we got a problem with, a recurrence of breast cancer? Leg pain, is it neuropathy? Or because the patient had chemo can cause neuropathy, or is it secondary to something else like diabetes? Or actually, is it a metastasis from the breast cancer? And or could it just, like I said, be good old Arthur because the patient's aged? That is another reason, again, why I reiterate understanding the body, the mechanisms of the body, understanding the verbiage, the proper terms, and also the disease process. So this would be considered disease process, a cancer metastasizing from one area to the other. Do you have to have this memorized? Absolutely not. Is it good to have stored away in the little gray cells? It would be easy for you to probably remember if you make a note. Where does breast cancer like to go? It likes to go to the bones. So again, that is something you might just want to make a little note of to help further your awareness of the body. Now, let me go back. I don't want to end. I want to actually go to this website. Let me pull it over here. I'm on multiple screens, so I got to get my mouse in the right place. Forgive me while I do that. And I want to show you that cancer where I got, or the site where I got that statistic. This is Verywell Health. It is a great research site, and they like to use the verbiage as a patient is researching information for themselves, but the information they give is pretty high level. So I would encourage you to bookmark Verywell Health and use that to expand your knowledge base. So this was that article that was stated that in 2013. And when I do research, excuse me, I want to make sure that I'm not getting the information off Wikipedia, but that I'm getting it off of a valid site. And this is one that you'll be able to go in and do searches. Say you want to look up prostate cancer, maybe you want to look up COPD. You can go up here into the search bar and you can do that. And it will also, another little tip, I liked this because look, you could actually have that in there. But I did pull some information for you there. Then whenever you see like this little 9 right here, that means they have cited another source. So you can hover over that. Sometimes they don't have that ability, but then you can go and look at that article for even higher specificity or more education regarding something. And sometimes they put those down at the bottom, depending. But this particular site, you just hover over. If you hover over anything that is blue, then you know it's got a hyperlink. Okay, so I did want to show you that. Now I also want to show you another site, that Auckland Radiological Center. This is a different type of site. This is usually based on giving information to providers, and so a little higher level. Now, there sometimes, because of that, you have to pay for the information. You notice here it says the Cancer Society of New Zealand has more information about bone metastasis, which can be accessed here. So you can hyperlink over to that site, and they will also give you resources that you can link into. But I noticed here you can find out who the providers are that were giving the information. Okay, and resources sometimes are linked here on the bottom, but these often are for providers to clinicians or other people at a higher level that are in the medical field. Okay, not a patient coming in to research bone cancer for themselves, right? So again, understand that may have some verbiage that you may look at and need to make notes on, but a very reliable source. And then I wanted to bring in Find a Code because I wanted to show you that depending on whatever encoder that you use, and I know we've said several times that we like Find a Code because it is so educationally based. Now, there are others that will have similar content, but I went ahead and put in the code for secondary malignancy of the bone, and notice this is where I got that information about how that works, okay, and where it likes to go. So when you use an encoder versus your manual, and you cannot use an encoder when you test, more often this is what you're going to get used to because they're going to provide one most likely wherever you work, or if you get one that you particularly like. I've done jobs where they said, well, we have Encoder Pro that you can use. Well, you know what, I already have Find a Code and I like it, right? So you may find a program that you really like and works well with your learning style, and plus you can make notes in there. So what I wanted to show you is how this works. Notice that when you open up your manual and you go to C79, that's going to tell you that it's a secondary malignancy and it's neoplasm of other and unspecified sites. So you think, well, how come bone is other? Well, it's because it's such a large portion of the body. And then secondary for bone and bone marrow would be C7 9.5. Now, it's yellow or highlighted because I specifically picked bone versus bone marrow. And another little teaching point here is to tell you bone and bone marrow are two different areas of the body. If they're going to test the body and see if the patient has a liquid cancer like leukemia, they'll tap the bone marrow. And if they think that the patient has bone cancer, they'll go in and they'll take a piece of bone versus tap down into the bone marrow. And when they check bone marrow, they usually tap the pelvis, right? And they just do a punch biopsy and go down into the bone and kind of aspirate out a little bit of that. If they do bone, then they'll tap down in there, take a chunk of bone, and then test it. So it is different, bone marrow versus bone. And then notice that as these, they're alphanumeric, so they're in a sequence. The next is secondary malignant neoplasms of the ovary. And you think to yourself, wow, bone and ovary right there together? What's the rhyme or reason for that? Well, it's because the code said, the sequencing of the code. I wanted to give you that additional information so that you were able to go ahead and research further. Now, Find a Code also has some additional helpful tools, and I'm very much involved with risk adjustment, right? You hear me talk about that all the time. So let's talk about how it risk adjusts. We're in 24 right now, so that's the one we look at. 8, metastatic cancer and acute leukemia. Why is bone cancer and leukemia linked under the same as an 8? They carry the same HCC because bone and bone marrow, right? It is a type of cancer that likes to spread. And it's one of the more common cancers that breast cancer likes to go to, and breast cancer is very common, right? So note here, metastatic, meaning it's moved. That means secondary cancers and acute leukemia. All right, now let's go look up here at primary bone cancer. So we usually will have an excludes that will tell us And I think it was, let's see, it didn't exclude, didn't have that. So this is how we would go. I'll just show you the neoplasm table. So I would go into the diagnosis, and so you're going to open up your manual to your tabular, and then of course it's in the ICD manual. Then I'm going to go to neoplasm table. And so it's telling me now I'm going to be referencing the neoplasm table, and I'm just going to type in bone. And I don't want a particular area of bone, so I'm just going to pick bone in general. So I have two choices. I have bone, periosteum, and neoplasm, neoplastic. So let's look at the difference between these two codes. So I'm going to open this in another link, and then I'm going to open this one into another link. So what is 80? Cancer not otherwise specified. So that is malignant cancer, primary, the start of primary cancer that is unspecified as to where it is. So C80.1, if you ever see that code, that means that the location has not been noted. And they like to throw that in on test questions as one of the options. So again, you might want to note that in your manual, and that this is cancer NOS, not otherwise specified or unspecified. And then malignant neoplasm of the bone, and then it includes the cartilage, and then it says unspecified. Now, note here, this means, why are all these excludes here? Because it's higher specificity. This is kind of neoplasm of the bone, not telling what part of the bones, right? We have a lot of bones. And that if we wanted to get to a higher specificity of, okay, well, of the limbs, and then note the point dash, well, that's because our limbs have laterality and we have more than one limb. So is it upper or lower limbs? If it's lower limbs, then that's the legs. Is it the right or left? Is it unspecified? Is it bilateral? Right, so that means there's more. Notice the larynx. The larynx is actually a bone. Okay, so that might be interesting to you, or actually kind of a cartilage area. Now let's go look and see what HCC it pulls, and it's a 10. So don't say that this always happens. However, when you have a category and the code, the HCC is lower, so we went from a 10 to an 8. Primary cancer is a 10, secondary cancer is an 8. And that means that it's more complex. The patient is sicker. So therefore, the weight of a 10 versus an 8 is less money, less revenue. And I think I can even click on this. Yeah, here we go. It has a risk score, okay, of all of this information. So if the patient is in an institution being treated, things like that. Then notice here, if we go down and we looked at, not that one. Oh, I already got rid of the secondary. Let's look at the secondary bone. And I can show you the difference there. So that's the secondary, and we knew that was an 8, right? Let's go see how that scores out. Wow, 1.303, or a 2, almost a 3. That is a huge risk score compared to 0.4. Okay, so that tells you that it is more complex. It's a more severe once that's metastasized. And that's also why you don't want to make a mistake and code something as primary when it's secondary. Okay, let's go back to, I think I may have lost my slide deck. Possibly I did. Let's see if I can go back one more. Click on that. Well, the only thing left in the slide deck was the to show you the resources that were on the resource page. So let's answer some questions real quick. And I'm going to go back up to the top. I don't see. Whitney's saying that she's had a lot of charts come through where the people have breast or bone cancer directly metastasized to the brain. Yeah, I've seen those too. And when you have metastasis to the brain, not original primary brain cancer, but the cancer has traveled to the brain, it is usually a lot more complex and severe. So those people are usually people that tend to go on hospice. Not always. If cancer metastasizes to 2 sites, it does not matter which is sequenced first. That is correct. It does not. Usually what I like to do, though, is go, I call the waist the equator, and so go above and below the equator. If one is above the equator, like lungs, and the other one's ovary, then I'll list the lungs first and then the ovary, but it really doesn't matter. It does matter, however, if that's the cancer that's being treated that day. So it's lung cancer and then they go to a pulmonologist, or it's ovarian cancer and they're going to the OBGYN or whatever, then that would make a difference. But I like to start at the top and go work down. My question on cancer: how long does it take to really be over a cancer illness? I've heard 5 years, but docs must document history or current cancer disease, right? That is correct. They are never over certain cancers. There are codes for in remission, right? And so that is a history of cancer. Let's go look at that real quick just to show you. So let's go to ICD-10. We're not going to go in the neoplasm table this time. We're going to go to the index and let's look up cancer. Let's just type in history. Okay, history and personal history of. So look at all the things we get here. So let's go to cancer. Personal history of cancer, C. Personal history malignant. And here we go. Z85.9, which 9s are overall usually unspecified because we didn't give a specific area, right? And then 8s are usually other when they're after the decimal. So other stands for there isn't a code yet for the specificity that's been given, that's been documented. But unspecified means we don't know yet. Either they didn't document or we don't have the information yet because we're still waiting for tests. So there we go. Personal history, malignant cancer, unspecified, but look at all the areas. So let's just say personal history of neoplasm of the brain. And when it's a history of, they don't care if it's primary or secondary. So there you go. And does it risk adjust? No, because it's no longer being treated. So therefore the patient doesn't get it anymore. Okay, so it carries weight, but not the same type of weight. And let's see, other questions. I've seen osteoporosis documented in people in their 30s. Yes, I know osteoporosis code says age-related, but if a person's young, what would be the contributing factor? Well, there is more than one type of osteoporosis. There is senile osteoporosis, right? So let's go look at senile osteoporosis and look at the definition. So we're going to go back. Oop, that's the guidelines. I didn't want that. Sorry. I'm looking at 2 monitors, my little eyeballs. We want the index. And then osteoporosis. Male and females can have osteoporosis. So here's the different types. We have age-related, drug-induced, idiopathic, it came from something else. And if you have a 30-year-old with osteoporosis, there's probably some underlying condition. Senile and age-related mean the same thing. So I would find out which one it is. Uh, if it doesn't specify the type, then you can use this NEC. So let's look and see what that is. Without it's other, it's not just regular osteoporosis, it's other. And that's what you might want to code. Query the provider. But always with osteoporosis, there's two things they're asking. One, what type it is, and if it's current with a current fracture or not. Let's see what it says here. Is it age-related or second? Does it have a fracture? Those are the things you need to know. And again, primarily, yes, senile or age-related, but it could be secondary. In a 30-year-old, probably secondary. Hope that answered your question. I would query. Can some patients have CEA of cancer in blood but not affect an organ? R97. Let's go look at R97. Yes, they can. So an abnormal tumor marker is that they went in, they checked it, and they're showing that there's symptoms of ours are signs and symptom codes, okay? Nausea, vomiting, fever, things like that. So this isn't a specific definition. What this is telling you is, I thought I might give you some more explanation about it, but is that we have an indication that cancer could be present. There's something abnormal going on. The patient, we haven't found any cancer, but it looks like there's something, and so we need to watch it. It's a sign or symptom of possible cancer in the horizon. If it's documented as the patient has suspected Kaposi sarcoma versus malignancy of the lung, how would this be coded? I'm thinking R9 1.8 for lung, but I'm not for sure about the other. Okay, you cannot code Kaposi sarcoma without it saying the patient has Kaposi sarcoma. For one reason that is really that kind of drives this point is that Kaposi sarcoma is a opportunistic cancer, and it likes to people who have HIV it'll turn HIV into AIDS. So people that have AIDS, if they're going to get a cancer, a lot of times they'll get Kaposi sarcoma. So again, that's a reminder that, hey, this is a very specific type of cancer. Don't ever give somebody something by coding it without verification that's what they actually have. So if you don't know they have Kaposi sarcoma, if it's only suspected, then they don't have it. They're being, now if they have a malignancy of the lung, then you would code that it's primary cancer of the lung unspecified. Okay. If they say, yeah, that's cancer, we just don't know what type of cancer it is, then you would code it. I would not use an let me show you the R91.8 code. Because remember, we are coding for statistical purposes. Okay, so there's a mass in the lung, and this is a code that would be used to have further testing done. The ICD codes validate medical decision making, and that's why they're so important for E&M in 2021 with the changes that have happened, is that we want to make sure that we're always validating why are we having all these tests done. We got to pay for these tests. Oh, well, because they're an R91.8. There's something in that lung, and we need to know what it is. So if the provider states the patient has a tumor, a cancerous tumor in the lung, this mass is cancer, then it's lung cancer unspecified. Right? If the patient, if the documentation says there's a mass in the lung, and that's all they say, but they suspect Kaposi sarcoma, then they are an R91.8 because they did not state the patient had cancer. You have to be able to prove somewhere else in the documentation that they have confirmed the patient has cancer, but they're going to do more testing to see if it is Kaposi sarcoma, which is a very specific type of cancer. So maybe they need to have a larger biopsy done, or they can do it with an image and they say, oh no, that image is telling us this is cancer, but it has the appearance of Kaposi sarcoma, and we know our patient has HIV. So we're going to send off a biopsy. Okay, so then your patient has cancer, unspecified. But if there's a mass in the lung, we don't know what it is, but our patient is HIV positive. And that means it is possibly could be Kaposi sarcoma. Then again, we don't know yet. They're an R91.8 and HIV positive. So hope that helps. Right? It's pretty black and white when it comes to that. Don't ever give us, I used to say, don't give people diabetes if they don't have it, just because they've got all the signs and symptoms, until it's signed on the dotted line that it's definite by the provider. They make the decision. Then you can code it, because you sure don't want to get that try to get that taken off somebody's chart. There's a difference in situ cancer and situ cancer, adenoma, carcinoma coding diagnosis numbers. Yes, there is. Yeah. Cancer in situ is a very specific type of cancer. It's encapsulated and it doesn't usually spread. Can it irritate and cause other types of cancers? Yes, it can, but it doesn't usually metastasize. And that's why it has its own column and own codes in the neoplasm table. Adeno and carcinoma, that just means that it's glandular cancer. So again, if you are wanting to understand cancer, you need to understand the anatomy, because adeno means gland, and that tells you right there. Sarcoma is usually used to describe a type of bone cancer. Or even bone marrow cancer. So liquid cancer, I think, is sarcoma. I know pain and anemia disease comes in different categories related to cancer. Is cancer a forever disease? Well, let me tell you this first. Cancer and anemia and pain are all codes that you're going to see together. Often patients will get anemia due to the chemo or the medication they're taking for the cancer, so through the treatment that they're getting, or it's just because of the type of cancer they have. If they have leukemia, they're going to be anemic in one way or another. They could be low on white blood cells and red blood cells. It's common. So are they anemic due to the cancer, or are they anemic due to the treatment? There's two separate codes for that. And you do need to know the difference, because that is something they will test you on when you go to take your exams. The other part of your question was, let's see, are they related? But is it a cancer? Is it a forever cancer? Liquid cancers are forever cancers. Now, can they be in remission? Yes. Meaning they're not causing any problems, they're not metastasizing anywhere, but they cannot say 100% with 100% accuracy where the cancer is, and if there aren't cancer cells floating around in liquid. They just can't. They say that with bone cancer too, because bone is all over your body. So just because you had bone cancer in your leg doesn't mean that you haven't developed bone cancer cells in your skull, because the bones are all, connected to each other in some way. And I don't mean literally connected as in a pathway. I'm saying that your body is producing bone cells. And if those bone cells are abnormal, therefore they can produce abnormal cells anywhere. Okay. So yeah, if you ask an oncologist, they would tell you that, yeah, they're a forever cancer. Do you still have to have treatment forever? No, not necessarily. But But will you always be aware that it could come back? Yes, but that is true of every cancer, quite honestly. Now, if you're 20 years out, you're probably okay. That would be a good topic for list of forever diagnosis codes versus diseases that never get cured. Excellent, Jane. You should put that in the topic request. That's a really, really good one. I like that. Thank you. Okay, guys, we are on the hour, and I hope this has been beneficial to you. We'll continue to do student webinars where we take, individual little topics that I know that you'll be tested on or that people struggle with, and kind of unpack that for you. And thanks, Jane, for that question. Those were all really, really good questions tonight. And if we didn't get to your question tonight, remember, go out and ask it in the club. So we'll be able to answer them there for you, or ask your instructor. Right. Bye, guys. Thanks.